good evening, everyone. I would like to formally welcome you all to the STEP program, which is the Star Teachers in Plastic Surgery. And the motto of this program is to learn, to contribute, and to encourage the younger generation. So the episode today is Season 1, Episode 12, and we have two topics, two sessions. The first session will be, the topic will be our initial experience with vascularized omental flap transfer for lower limb lymphedema. The speaker would be Dr. Ramani. He has done his MCH in plastic surgery from Madras Medical College, Chennai from 2009 to 2012. And he has been a specialist resident at Tata Memorial Center, Mumbai, and international visiting scholar at the Asan Medical Center, Seoul. He is right now a consultant at Manipal Hospitals, Whitefield, Bengaluru. His fields of interest are reconstructive microsurgery, onco-reconstruction, head and neck, breast, hand trauma reconstruction, lymphedema surgery, aesthetic surgery, burns, and general plastic surgery. And we are very happy to have Professor Wei F Chen as the moderator for this session. He needs no introduction on the world stage, and he is the clinical professor of plastic surgery, the head of regional microsurgery and supermicrosurgery, the co-director, Center for Lymphedema Research and Reconstruction, and Department of Plastic and Reconstructive Surgery at the Cleveland Clinic, Ohio, USA. We welcome you, sir. We share our love and affection from India. And with this few words, I hand over the session of our initial experience with vascularized omental flap transfer for lower limb lymphedema to Professor. Please go ahead, sir. Yes, sir.
Okay, so I suppose I'll do a very brief introduction about the omentum lymph node transfer. So as you all know, that lymphatic reconstruction has become quite popular in the recent days, and pretty much everything started from lymph node transfer. And lymph node transfer was started in around 1990. It's somewhat controversial who started it first, whether it was Professor Han-Chi Chen or Professor Karin Becker. We'll just leave it at that. Both of them started at around the same time in 1990. And so at the time, lymph node transfer was the only way to reconstruct lymphedema. Until 2000, Professor Koshima started the LVA procedure. So now we had two procedures that we can offer the patient to treat lymphedema. And since 2013 or so, after the first report of donor-site lymphedema, we realized we can cause lymphedema by taking lymph nodes. So all of us started looking throughout the body to try to find out where can we take lymph nodes safely. And then we have various lymph nodes that were created: lymph node transfer, supraclavicular, laterothoracic, omentum, small bowel mesenteric lymph node. Omentum is the one that has gained the most traction, and as of today, I think looking at around the world, definitely that is the case in US. For surgeons who prefer lymph node transfer or lymphatic tissue transfer, omentum is the most popular option. So I'm very eager and curious to hear the upcoming presentation. And without further ado, let's turn the mic to our speaker.
Yeah, just yeah, thank you. Thank you, Professor Karthikeyan sir, for giving me this opportunity, and Professor Wei for accepting to moderate this session. And without without saying anything, Professor Wei has given the history regarding the omental lymph node transfer. So I hope I don't have to answer those questions. Thank you. So I would like to share just our experience with free omental lymph node transfer, which we have done for purely unilateral lower limb lymphedema. And my interest with lymphedema treatment started when I had been to South Korea for the World Society for Reconstructive Microsurgery meet. And that is when we had the interest to start the treatment for lymphedema. So the center where we have done all the cases is at Manipal Hospitals, Whitefield in Bangalore. And it's a single institution experience with a duration of around 1.5 to 2 years of follow-up, where we've totally done around 4 cases of unilateral lower limb lymphedema, and 3 of them were cases of primary lymphedema, and 1 case was of secondary lymphedema. All the cases were done with laparoscopic assisted vascularized omental lymph node transfer. With regard to the workup of the patient, apart from the routine investigations, we basically do the ICG fluorescence scan and the volumetric analysis. The lymphoscintigraphy and MRI is not a routine investigation. Once we take the circumference measurement of the affected limb and the normal limb, we formulate it into an Excel sheet and then measure the volume. What is the difference between the normal limb and the affected limb? So we have the volumetric analysis, the formula which is already there, the truncated cone method, and the readings are taken at specific intervals of say around 4 or 5 centimeters from the medial malleolus if it is the lower limb, and then it is charted into the formula. Nowadays we feel that this the world over this is being accepted as the formula to to calculate the lymphedema extremity index, which is definitely a useful measure for preoperatively and postoperatively. And then we do the intestine green lymphangiography. Is a routine technique where the ICG is diluted and then it is given in the second and fourth web space. We prefer to give it over the medial aspect and then even on the lateral aspect, posterolateral to the tendoachilles. And then in the dark room, repeated scans are done until we see the dye reaches the groin. So this is the probe, which is a near infrared LED detector, and the machine which we use. So based on the flow of the ICG, the different patterns have been classified, which is standardized. We have the linear pattern wherein we can see the lymphatic channel taking up the dye and then reaching the destination, that is the lymph node in the groin in case of a lower limb. And depending on the amount of dermal backflow, the classification as a splash or a stardust at the diffuse is taken. And this is also the management based on the ICG staging, wherein from stage 1 where you may have a linear and a splash pattern, and from stage 2 to stage 4 you have an increasing order of stardust pattern, and then in stage 5 it is all a diffuse pattern. So this treatment modality also changes, wherein as the severity increases, you can see that the elastography of the lymphatic channel, you can see that there is a increasing amount of sclerosis in the lymphatic channel. So the pumping capacity of the lymphangion is reduced. So if based on the ICG also, if you can see that in linear or in the splash pattern, you can get away by doing an LVA, and the lymphatic channel will have to pump the lymph into the veins. And as the severity increases, you see that the lymph node transfer, or in the late stages, it is going to be a liposuction and debulking procedure which is done. So the basic treatment comprises of, as Professor Wei said, that conservative management with compression and manual lymphatic drainage and complex decongestive therapy form the core of the treatment, be it before surgery and after surgery also. And with regard to surgical management, we have the lymphatic venular anastomosis and the lymph node transfer or liposuction with compression and the debulking procedures. So here I would like to share the cases which we have done and what difficulties we have faced. and what are the lessons which we have learned, and there are lots more to learn. That is what I would say. So the first case was a 26-year-old male with a history of swelling in the right leg from the age of around 10 years. When he was 10 years old, he had main complaints of swelling and occasional discharge from the foot. And then on examination, there was an edema up to the knee with minimal secondary skin changes like hypertrophy and the base of the toes. So this is his affected right limb. You can see that the swelling is there from the toes, the base of the toes, the dorsum of the foot, and up to the knee level. And this is the photo from behind, where you can see the bony landmarks are not clearly visible. The secondary skin changes are visible only here, and the skin is completely normal here except for the pitting edema. And so we did the ICG scan, which showed that the dye did not travel beyond the medial malleolus, and there was a lot of backflow, and he was into the category stage 4. So we convinced him that he would need a lymph node transfer from another site, and so as to tackle his issue, he got convinced for a laparoscopic surgery. And this is our bariatric surgeon who is harvesting the lymph node, and you can see the gastroepiploic vessels. And this is the harvest. So once the mini incision is made and the omental flap along with the lymph node and pedicle is delivered out. Yeah. So this was the flap which was removed. Though we did use the whole amount of flap. Here is the lymph node along with the pedicle, and this is the whole of omentum along with its vascular arcade. And so it's a two-team approach, wherein the laparoscopic surgeon is doing the harvest at the abdomen site, and we at the leg end start to explore the vessels, we prefer the anterior tibial. In all the cases we have done with the anastomosis with the anterior tibial vessels, and we prepare the subcutaneous pocket, debulk the area, prepare the recipient bed, and then the anastomosis is done to the anterior tibial. The vein also is, you can see the gastroepiploic vein, the size of the vein, and for the first case we did the primary closure. This is a glove drain which was kept, and this is the tip of the flap. This was kept for monitoring purpose and to see the color of the flap basically. And I will just show a video of the harvest. So we were lucky enough to have our bariatric surgeon who's regularly doing bariatric procedures. So we clearly told him what was our requirement, and the handling of the flap is very, very important, because half of the work is done by them now instead of us, because the flap harvest is being done by them. Our job is mainly to create a pocket and prepare the recipient vessel and do the anastomosis. So this becomes the main stage of the procedure. So every time we being even at the leg end, you have to keep seeing what is being done in the monitor, and when they deliver the flap, we will have to keep a watch. You can see that the handling of the flap when they take it out from the abdomen. So they should not crush the pedicle or the flap tissue. Yeah, so that was the harvest, and once we did the harvest, we took it to the foot end, and this is the scan with the ICG scan machine, where we give the dye intravenously after the anastomosis is done. And this is the flap which is on the dorsum of the foot on a wet mop. So once the dye is given, you can see that the dye is traveling into the arterial system and entering the flap. So immediately it gives the fluorescence. You can see your flap is perfusing well, and even the venous return can be seen. This is just to confirm the perfusion. And one more advantage with the ICG scan on table is, if any part of the flap is not well perfused, then you can always discard that part of the flap. So the first case, this is how it was on table. And we had an issue with this patient. At the second day, we had put a slab to prevent any movement at the ankle, and but the patient clearly said that he had a lot of pain on the operated area. So on the second day, when we opened the dressing, we removed all the stitches. We found that there was a clot, so we had to take him to the theater the same day, and we removed all the blood clots. We found that the flap was healthy, and then since we did not do anything as such, because we left the wound to heal by itself. We didn't do any grafting or secondary suturing. We left the wound to heal by itself, and we called him later at around 4 months, because he was not from the local town, so he had to come from a far off distance. We did the ICG lymphangiogram. At 4 months, we found that the dye was traveling into the venous system, and this is his follow-up. I'm sorry for the background, because he sent it from his hometown. He isn't from Bangladesh. So you can see that the swelling is reduced in the leg part, though the foot, the dorsum of the foot, there is still swelling. So what we found out was, even if there is some scarring or fibrosis because of the surgery, it will not give the optimum result, even if you're doing a omental transfer. The second case, she is a 56-year-old female. She had a history of around 15 years history of swelling in the right leg. She was a bank employee who was always sitting in the office hours, and her only complaint was repeated episodes of pain, swelling, and discharge in the foot. And when we did the ICG, we found that there was no clearance of the dye above the ankle, and it was a complete stardust pattern, a stage 4. Yeah, so this, she didn't have any previous surgeries in the abdomen, or she didn't have any other diseases. And when we opened up the leg, we explored the anterior tibial vessels, and then we thinned out the subcutaneous tissue. What we found was, in this lady, as soon as we put the incision, a lot of lymph oozing out from the incision site, and we had to debulk the tissue. But we made sure that we maintain the thickness of the skin flap on either side in order to prevent any skin necrosis. And we also made some incisions on the deep fascia. And once the flap was harvested, we have anastomosed it to the anterior tibial vessels. This is the final insert. But whatever amount of debulking you do, we will not be able to close the site primarily. That is what we saw in this case. You can see that the skin has shrunk so much here at the site where the debulking was done, but still we were not able to close. One maybe because the amount of omentum which we have used was more, or we didn't know, but we didn't want to have a compromise in the flap, so we left it open, and then we grafted the flap. So this is the flap and the insert. Sure, we had a complication again. That was a hematoma under the graft, and we lost the skin graft. We found that the flap was fine after the debridement, so we took her for a grafting at a later stage. You can see the reduction in the circumference of the leg. This was on the second week after surgery. And interestingly, she didn't come for at least 6 months after surgery, but you can see the pre-op picture, the swelling, and the post-op picture. You see that there was no wound left at all at the site where the graft was lost, except for this area. The whole leg, the swelling had reduced. We had just advised her to follow compression and massage, which the physiotherapists in our department had taught her how to do the manual lymphatic drainage. So she was just following that. Apart from that, the skin care. So she didn't have any repeated episode of lymphangitis later. She was in fact happy with the result, and she could resume her work as well. This is another case, a 52-year-old lady with swelling of the left leg for the past 10 years. And an ICG, we found that the dye could not reach the groin from the site where it was injected, even after 24 hours. So we convinced again for a laparoscopic lymph node transfer. And here it was an intraoperative difficulty which we had to face. We explored the vessels, the anterior tibial vessel, but for our luck, when the bariatric surgeon had harvested the flap, we found that the lymph node and the gastroepiploic vessels were separated from the rest of the omentum. So, but we used this as a flap, and then I'll show you in the next picture. We had a vessel, we had a pedicle in the omentum as well. So we used it as a double flap. So this is the first flap. You can see the artery and the vein done as a end-to-side anastomosis here at the ankle, and this is the omentum, because this also contains the lymphatic lakes. So we didn't want to discard that. We had a good vessel. Even though the caliber was around zero 0.9 to 1.2 millimeters, we did the anastomosis at the level of mid leg, both end to side anastomosis. And this is how it was after the closure. Luckily, we didn't have any complication in this. This is on the third day, and this is the same patient at 2 weeks. You can see the graft is completely settled, and this is the preoperative photo, and this is the postoperative photo. The swelling is considerably reduced within 2 weeks in the leg. Up from the ankle to the knee level, the swelling is considerably reduced. This is the fourth case where we had a 32-year-old male with history of swelling in the left leg for around 10 to 12 years. But here the patient had undergone a fasciotomy for cellulitis of his foot, where he was working in Middle East. I didn't have any other details regarding that. You can see the previous fasciotomy incisions on the dorsum of the foot. Nothing, no interventions in the leg as such. But he complained of swelling on the foot and up to the leg as well, the left side. So we did the volumetric analysis. We found out that there was a significant difference of around 15% on the volume. And here, this is how we exposed the recipient area. We prefer to make such incisions on the deep fascia so that the subfacial lymphatics are being drained by the lymph node flap. And this is the picture of the harvest, the pedicle being ligated, and the flap. Yeah, this is the anastomosis site here. Yeah, you can see the vein, huge in caliber. So you have to be very delicate when you handle the gastroepiploic vein and the artery. This is the final insert. We didn't close it primarily. We have put a skin graft on top of it. This is the picture after 2 weeks. He was lost for follow-up, and because of this pandemic, they're stuck in their hometown. They're not coming back for the review. So basically, the lessons what we have learned was management should always be in a comprehensive way. Like Professor Wei had mentioned, it should always be with lymphatic massage and surgery as well, if and when needed. And what we found out after the start of lymphedema treatment was awareness among the clinicians. Most of the clinicians were not aware that lymphedema was treatable and who was supposed to treat it. So we found that all the cases were landing up to the Department of Vascular Surgery. And when we spoke to the others that these are the treatment options which is available, be it lymphovenous anastomosis or lymph node transfer, then that is when they started to send patients to our department, because all they knew was just debulking, excision, and skin grafting. And with regard to omental lymph node transfer, all the 4 patients, we found it easy to convince them for a laparoscopic surgery, because the moment you say a lymph node transfer is needed to cure or alleviate your problem, they would definitely ask the next moment that what happens to the site from where you take the lymph node. So for us, it was easy to convince, and since the donor site morbidity is very minimum when compared to other sites, we found that omental lymph node should always be the first choice which should be offered to the patients. And it also has the advantage that it is a 2-team approach. And luckily, we had a good bariatric surgeon with us. We finished the whole procedure within 3.5 hours. And the donor site complications, what we had seen in all the patients was just prolonged ileus. But with respect to the recipient site, we have seen the complications like hematoma, graft loss, and luckily we have not seen any skin necrosis. And one more thing is the quality of life after transfer is patients are clear that their rate of infection or the inflammation in the leg, the affected leg, the episodes are very reduced after the transfer. Even though we have found that the swelling of the foot takes time to reduce. Thank you.
Bravo, that was wonderful. Okay, so we will start the discussion now. How much time do we have for the discussion session?
You have another 25 minutes, sir.
25 minutes. Okay, great. First of all, any question from the audience?
There are a few questions in the chat box.
Oh, okay. Yes, I can read the chat box. Okay.
Ramani, can you just stop sharing the screen?
Yeah, sure. Once again. Okay. Once again.
All right. Well, I can read off the question. Well, question from Professor GK. How far do the deep fascia incisions help in lymph drainage?
Yeah.
Question for our speaker.
Yeah. So, with regard to the extremities, be it upper limb and the lower limb, what they say is that the lymphatics, which are present in the above the fascia and below the fascia, when you put an incision, when you transfer a lymph node, and then you make an incision in the deep fascia, the subfacial lymphatic system helps in drainage of the lymphatics into the lymph node flap. And we make incisions only at the site where we have done the debulking and the exploratory incision is done.
Okay, another question from Dr. Shashank. How many venous anastomoses were done? And also, any prerequisite of flap size or the number of lymph nodes that need to be transferred?
As far as the greater omental lymph node flap is concerned, you will have only one vein with the pedicle. And if you want to do we did one case where we did a double level. So only in one case we did 2 veins. And regarding the size, there is no prerequisite of a flap size or the number of nodes. In fact, you can palpate the nodes at the pedicle, but I don't think you will be able to count it that easily. And the flap size is, you will have to tailor it according to the patient's requirement, that is the size of the limb.
Well, that's all of the questions that I see in the chat box. Any other question from the audience? Okay, well, I will share a little bit to some comments. And I will respond to that last question about the number of lymph nodes. So for years, surgeons debated about how many lymph nodes are needed. And it's generally been assumed that more lymph nodes are better. However, there's never been any evidence. So surgeons who like, say, for example, segmental flap would say segmental flap has more lymph nodes and therefore it's better than the groin, and so on and so forth. But it's important to know that there's never been any evidence that more lymph nodes are better. And there's also never been any evidence conclusively that one flap has more lymph nodes than the other. That's the first thing. And when it comes to omentum, in addition to just the lymph nodes, there are lots of what we call the lymphoid lake or the milky spots. We know omentum is enriched in lymphatic tissue. So one idea that we need to think about, especially with now the success of lymph vessel transfer, is it the lymph node or is it the lymph vessel that's really helping? So that's an important concept. I see more question coming in. Dr. I'm sorry, I'm going to be butchering your name, Dr. Thiagarajan.
TK.
Dr. TK.
Yeah.
Okay. What happens to the skin graft in the long run? Can we excise the graft at a later date or close the defect? For a moderate lymphedema, grafted leg is as bad as swollen lymphedema cosmetically. Speaker,
Yeah. So we have not excised the graft or anything like that, because our follow-up has been for a very short period. I would say just one and a half year. And you would have seen that in the second case, we had done the skin grafting for the second time, and then the whole wound shrunk to the level that we were not able to identify where the graft was. And probably we have to see whether we can excise the graft and then close the defect at a later date. I'm not sure.
So I can help with that question. So the as many of you know, we started out doing lymph node transfer a while back, and one issue that we encounter is the cosmesis. So lymph node transfer, if you want superior cosmesis, you should do a proximal transfer. So that means you put the lymph node in the groin. However, when it comes to effectiveness of the procedure, we found that distal transfer, the way our speaker performed, placing the lymph node at the ankle or at the foot, tend to work better. Patient responded better. However, then the flap become very visible. And if you have a bulky flap, if you have a heavy patient, you'll have a bulky flap. And you will have difficulty closing the wound. And we also needed to skin graft really frequently, because if you force to bury the flap, then you can cause the flap to become compromised. There's no easy solution. And later on, when the patient has decompressed, sometimes you develop sufficient skin laxity, and then you can partially bury the flap. But I think one of the drawbacks of lymph node transfer is always cosmesis. You're adding more bulk to a limb that's already bulky. To me, that is a drawback. And so one way to resolve that is to resort to other treatment options. And as many of you know, I have migrated away from lymph node transfer, even though lymph node transfer is a very effective treatment option. And when I was doing it, I was mostly happy with it. But cosmesis was also a problem that we couldn't resolve. And so I said one solution is to just not do it, to do something else. Okay, I see another question from the audience. Dr. NS, what is the post-op protocol that you follow with respect to compression and MLD?
Yeah,
that's a great question.
Yeah. So with respect to compression, since most of the wound healing happens within two to 3 weeks, we start the compression after a third week. And we have not advised any of our patients to use the lymphedema stockings, but we just used only the elastic grip. And lymphatic drainage manually has been, they go to the physiotherapist, and under our guidance, we teach the patient how to milk from distal to proximal gradually, and which needs to be done at least twice a day. And we tell them that this has to be continued for at least 4 to 6 months.
Okay. Another question from Dr. Sandeep. How long do you wait after an episode of lymphangitis to perform lymph node transfer?
Theoretically, I would say 2 to 3 weeks. We have not had the patient who came with an episode of lymphangitis, but we would say 3 weeks until the superficial infection settles with antibiotics.
Okay. From Dr. Karthik, which is a better procedure for lymphedema, omentum, lymph node transfer, or skip flap? Any studies done for this? Dr. Venkat, do you want to respond?
Yeah.
So comparing skip flap and omentum. So I would say this is a little bit of they're a different category of procedures. So the skip, I'm assuming you're referring to the ultra thin skip flap. Ultra-thin skip flap, excluding the deep fat layer, would be lymph vessel transfer. The full-thickness skip flap is essentially a free grown flap. That's the grown lymph node transfer. So these are two different procedures comparing to the omentum transfer. Would you like to respond to that?
Yeah, we have not done basically the vascularized lymphatic vessel transfer. Okay, and we would like to do definitely, but we are looking to collect a good number of patient series for laparoscopic omental transfer or lower limb lymphedema, which we feel, as I said, being a two-team approach, we are able to give good results and finish the case faster, which is what everybody would like, both the patient and us.
Okay. Next question is actually for me. If the patient presented with lymphedema of a single lower limb, a 3-year duration with no obvious skin changes, how would you approach the patient and how would you take a decision? If there were gross skin changes, how would you approach the patient? Okay, I think this is, so I will share with you my take on some of these cases, and the question is also relevant here. So I saw that in, I think, the first and the fourth cases presented, both patients seem to demonstrate a good amount of lymphedema-related lipodystrophy, or what we call solo predominant patient. So in these patients, their bulkiness is no longer just fluid. Bulkiness is also partially solid or lymphedema-related lipodystrophy. I will share with you my screen. Can you see my share screen now?
Yes, sir.
Yes. Yes.
So this would be an example with a patient with early elephantiasis. So for someone like this, if we treat the patient with physiologic reconstructive procedure, whether it's LVA or lymph node transfer or lymph vessel transfer, so patient would still improve. However, the size of the leg is not expected to be significantly reduced because the physiologic procedures are not expected to dissolve fibrosis and lipodystrophy. So for someone like this, our preference is to treat the patient with liposuction. And we would also do fasciectomy for compartment release. This is what their fascia looks like. It's always very dense, like cement. And we trim the skin with our flying squirrel technique, as many of you know. So that's the kind of result you can get on the table. And so now this patient is ready to receive physiologic procedure. So after debulking. So this is our preference. I saw that in some of the cases presented, the patient clearly already had lymphedema fatty tissue, and they're best treated, in my opinion, with a debulking procedure first. Okay, so it looks like next few questions are also for me. In the interest of time, I'm gonna quickly look at them, and then I will pick the ones that I felt would be probably of interest to most people. So we have a question asking, what's my flap of choice for unilateral primary lymphedema? Well, next question is the same. What's the best treatment for congenital lymphedema in children? So let me stop sharing. So the treatment, actually, our speaker, if you want to discuss about your current approach, how would you approach primary lymphedema? I think it would be of interest to all of us also, and then I can share my take.
Ramani, Dr. Ramani?
I don't have the slides to present, but you can take over, Prof. That would be the best thing.
So when it comes to primary lymphedema, well, I can share with you a finding that's ahead of print. We actually haven't put this out yet. So primary lymphedema, an important concept is that it's not primary lymphedema of the leg. It's always a global hypoplasia of the entire lymphatic system. So the patient with primary lymphedema, we are quite concerned about causing lymphedema in other parts of the body. So after we made this finding, global lymphatic hypoplasia, we stopped doing lymphatic transfer procedure, whether it's lymph node transfer or lymph vessel transfer in patient with primary lymphedema. We try to treat the patient as much as is possible with LVA. And there was another question asking for our protocol. So can you see the share screen now?
Yes.
Okay, so this slide shows our protocol. So one key message is there is a procedure for lymphedema of all severity. So for stage 0 disease, we treat with preventive LVA all the way up to Charles procedure. Here you can see the lymph node transfer, even though it's still on the algorithm. We actually no longer perform lymph node transfer for the reason I just mentioned. It doesn't look very good. Many of our patients complain. In terms of effectiveness, I have no complaint about lymph node transfer. I think it works great. And usually you have very happy patient in the beginning because their lymphedema symptoms were relieved. But usually after first year, after second year, now they're used to having a relieved lymphedema condition. Now they start to look for more. They start to find the appearance bothersome. So lymph vessel transfer wouldn't have that issue. And many of you have seen our lymph vessel transfer, so I won't bother showing it. There was, let's see. So I do want to share about the evaluation. Our speaker mentioned in the beginning how they use lymphedema index and the truncated cone formula to calculate the volume. So that was also what we did initially, but since then we found something that we like a lot more, and that's 3D scanning using this app right here. So you can see on the screen, this is an app-based software that you can install on your phone or on iPad. And actually I have a video of this, but I don't have it easily that I can pull up. Essentially, you can perform a 3D scanning of the arm or leg, and you can extract circumference at any given level. And it gives you a volume. So instead of telling the patient your arm is, your affected arm is quite substantially larger than a healthy arm, you can tell the patient that your affected arm is 725 cc larger than your healthy arm. And you can observe this differential improving or worsening over time. So we found this 3D scanning app to be very, very helpful. Another tracking modality that we found really helpful is the bioimpedance, particularly the quantitative bioimpedance that can tell you how much of the bulkiness that you're seeing is fluid and how much is fat. So that's something that I think for those of you who are interested in starting lymphatic surgery, you can try looking into. We found them very helpful.
Professor, there is one question on the live YouTube screening There is a question from Thomas Pacheco. Do you supercharge with some venous lymphatic anastomosis in the omental flap or just standard artery vein?
Is that a question for me?
I don't know. They're not.
Okay, well, our speaker, Dr. Ramani, if you want to.
No, we don't.
answer
We have
that.
not done it. We have not done it. We have just done the standard artery and vein. That's it.
So I can share with the audience that the whether it's the omentum or the jejunal mesenteric transfer. Several surgeons have reported that these flaps are prone to congestion, and some have proposed ways to circumvent the problem. And this is partially due to, if you look at the blood supply to these areas, they're vascular arcades. So these are not structures that receive end blood supply. So when we perform our anastomoses, end-to-end anastomosis may put the flap at risk of venous congestion. It's not used to seeing that much blood flow. So some have suggested doing end-to-side anastomosis instead, which is well, some feel that end-to-side is more physiologic, and even consider doing it as a flow through. If you take a segment of the vessel, including a branch, perfusing your omentum. If the flap is already congested, then yes, consider doing supercharging the vein. So this is a topic that have been described by people who prefer mesenteric lymph node or omentum.
So,
okay.
Would you like to sum up the session before we close the first session, Professor?
Sure. I will give a summary. So I think in general, it sounds like our speaker, Dr. Ramani, had a favorable response and favorable experience with the omentum lymph node transfer, and congratulations.
Thank you.
And I think overall it's great. We don't have enough surgeons helping this neglected patient population. And I don't know the situation in India, but in US, to do lymphedema surgery means you need to work harder, you need to get paid less. These are not money makers. They're hard to get reimbursed by insurance, but I think it's highly worthwhile, as I'm sure Dr. Ramani has experienced. These patients are very appreciative. And I think probably the two greatest rewards of lymphedema surgery is, one, as I said, patients are very appreciative because they've been turned down, bounced around everywhere, and they couldn't find real meaningful help until they found you. That's the first gratification. The second reward is that these procedures are fun. They're technical challenge, but if you can do them and you can do them effectively, very rewarding, lots of fun. So I would invite as many of you as possible to join us in helping these patients. And there are many unanswered questions. As I said, I don't do lymph node transfer anymore, and in my opinion, lymph vessel transfer is superior. And in my opinion, lymph nodes are just there for the ride. I don't think lymph nodes are the actual therapeutic component. I think it's the lymph tissue that you have transferred that actually did the job. But, well, prove us right or prove us wrong. Join us. Help these patients. Thank you.
Thank you so much, Professor. Thank you, Dr. Ramani, for a very nice talk. It's interesting, and that is what this program is about, bringing out your passions into the new fields. And the professor was kind enough to share his time and his experiences with us. As he said, it may not be very financially rewarding, but the interesting part is that it is most challenging, and we all like challenges. As microsurgeons and plastic surgeons, we are interested in challenges. I suppose that should be enough impetus for us to take up this field of surgery. Thank you so much, Professor. And thank you, Ramani, once again. We'll close the first session and we'll go on to the next session.